Okay, so to be on time, we will begin. So I'm very happy that all of you attend this meeting. I am Beatrice Gubis. I am the co-coordinator of the ERN-EuroBloodNet. That you know, it's the European reference networks for rare hematological disease. And it is, of course, my great pleasure to welcome all of you to this session of Thursday webinar. Our program starts in 2020, and it aims to promote innovative topics. And the purpose of it is, of course, to disseminate all the cutting-edge advances in the field of rare hematological diseases among health professionals. So just before start, I have to give you some rules. The first one is the fact that the webinar is recorded and it will be uploaded on our website on e-learning environment. And if you would like to appear, please don't use your camera, turn it off. And you can change also your name on the platform if you would like. And we also kindly inform you that your microphone is muted. If there is any questions, we will have a session through the chat, and of course, Graça will answer all the questions, and it will be at the end of the webinar, of course. So today the lecture is on the challenges in the management of HFE-related hemochromatosis. I'm really honored to welcome Graça Porto, our speakers. Graça, you graduated in medicine in 1979 at the University of Porto, and you specialized in hematology transfusion medicine at Santo António Hospital in Porto, where you hold the permanent clinical position, presently as chief consultant. Your clinic work was mostly devoted to the study of disorders of iron metabolism, running the hospital outpatient clinic for hemochromatosis. Among many activities, I would like to highlight a few dates. In 2016, you were co-author of the practice guidelines in molecular diagnosis of hemochromatosis, which are the MQM guidelines. In 2018, you became the coordinator in EuroBloodNet for the iron disorders. In 2022, you were co-author of the European Association for the Study of the Liver Clinical Practice Guidelines on Hemochromatosis. And also, very interesting, in 2023, you were also co-author of hemochromatosis and patient research priorities. So it's very huge, not only for as professional, but also for the patient. So I give you the floor, and thank you very much.
Okay, thank you, Beatrice. Thank you very much for this introduction. I have nothing to declare in terms of conflicts of interest. So the seminar today has three main learning objectives. First, to remind you of the physiopathology of hemochromatosis, naturally focused on the dysregulation of systemic iron homeostasis. Secondly, I will call your attention for the most recent update on nomenclature and classification of hemochromatosis. And finally, the main topic of the seminar, that is to address the challenges that we face today in the management of HFE-related hemochromatosis. So I will start by a very brief reminder of the system of iron recycling in the body that guarantees that a sufficient amount of iron is available for the needs, in particularly the production of red blood cells in bone marrow. iron needs are supplied by the iron in circulation, and this can be measured in clinical practice by the percentage of transference saturation. This iron enters the circulation mainly by export from the reticuloendothelial macrophages of the spleen after recycling the iron derived from the phagocytosed senescent red blood cells through ferroportin, that is the only known cellular exporter. Because there is practically no iron excretion by the body, this constitutes a very effective recycling system, almost not depending on external sources. But only a small proportion of the body iron is absorbed in the duodenum, also exported by ferroportin, to compensate the small amount of iron losses. But in spite of being such a small amount, iron absorption is a critical step to maintain iron homeostasis. Therefore, it must be strictly regulated. And the master regulator of iron homeostasis, as you know, is hepcidin, a small peptide produced by the liver, which function is to block the action of ferroportin and thus impairing the iron export from the duodenal enterocytes and from the spleen macrophages. So you can imagine hepcidin as a weight in a balance, maintaining the iron equilibrium in the body. If hepcidin is upregulated, there will be less iron in circulation. This is a very convenient physiological mechanism that, in the case of infection, may restrict the amount of iron available for the pathogens, a process that now immunologists call the nutritional immunity. As a matter of fact, before it was discovered as an iron regulatory protein, hepcidin was first described as an antimicrobial peptide. On the contrary, downregulation of hepcidin will increase iron levels, and this is the physiological response to iron deficiency to allow increasing iron availability for erythropoiesis. So in practice, the biomarker transference saturation is the surrogate marker of hepcidin activity. We don't need to measure hepcidin. We measure transference saturation. It is important to know that the liver, being the effector for hepcidin secretion, is also the sensor of iron needs. It is sensitive to hypoxia, iron deficiency, and increased erythroid demand through the so-called erythroid regulator ERFE or erythroferrone that will downregulate hepcidin expression. On the other side, it is sensitive to systemic iron overload through a membrane protein complex that is responsible to increase the hepcidin expression. These signaling proteins, namely HFE, hemojuvelin, and TFR2, are the ones that we will find deficient in patients with several forms of hemochromatosis. And that's why they are named globally as the hemochromatosis proteins. So hemochromatosis is basically the failure of this sensing mechanism. So a summary of the pathophysiology of hemochromatosis can be described as a stepwise process, starting with a genetic defect in one of the hemochromatosis proteins, resulting in defective hepcidin production, and consequently an increase in serum transference saturation and progressive tissue iron accumulation, first in the liver and eventually in other organs such as pancreas, the hypophysis, or the heart. It is easy to understand that if hemochromatosis is detected at an early stage and properly treated, it is an easily preventable disease, but it is a potentially fatal if it's left untreated. I confess I have some difficulty in placing in this staircase the arthropathy, which is undoubtedly one of the characteristic clinical manifestations of hemochromatosis, but whose pathogenesis is still very poorly understood and does not seem to be directly related to the degree of iron overload. It is indeed today a challenge for research to understand hemochromatosis arthropathy and how to prevent it. The clinical biomarkers of hemochromatosis are thus the increased transferrin saturation and serum ferritin as an indirect marker of tissue iron load, although very unspecific. The specific measures of liver iron overload are the liver biopsy, which is no longer used in clinical practice, but instead the liver iron quantification by MRI, which is becoming more and more widely used. I must tell you that serious efforts are being done today by experts in the field to establish reproducible cutoffs for scoring the severity of liver iron overload and so define appropriate reference values for the diagnosis of hemochromatosis. But this is an issue still in progress. But the gold standard confirmation of hemochromatosis is naturally the genetic testing. And because HFE-related hemochromatosis is by far the most common form of hemochromatosis, the first-line genetic test is HFE genotype. Regarding the nomenclature and classification of hemochromatosis, I should recall that at the time of the last EuroBloodNet webinar on hemochromatosis 4 years ago, there was still some confusion among clinicians regarding the HFE genetic variants causing hemochromatosis. But a strong consensus was finally achieved in 2022 among the members of the International Bioiron Society to definitely define what is hemochromatosis and what is not, and how to classify it on the basis of its genetic origin. So this is an important topic in clinical practice that you can review in this blood paper from Girelli and co-workers. So in more than 90% of cases, hemochromatosis is the HFE related due to homozygosity for the C2A2I variant, or very, very rarely due to compound heterozygosity of C2A2I with another very rare loss of function HFE mutation. The molecular mechanism is that the lack of expression of HFE at cell surface will abrogate the signaling pathway for hepcidin expression. So now, what about C2A2I and H6-3D compound heterozygous genotype? I know that for some time it has been considered a hemochromatosis genotype, but the recent nomenclature does not consider that. Instead, it considers as a susceptibility genotype for mild to moderate liver iron overload if there are other risk factors such as alcohol abuse, chronic liver disease, or dysmetabolism. There is nowadays a great debate among expert geneticists if the reporting of H6-3D should be excluded from the genetic test for hemochromatosis, given the confusion generated in clinical practice. At our laboratory in the Center for Predictive and Preventive Genetics in Porto, we are changing our practice to report only the C2A2I variant for diagnosis of HFE-related hemochromatosis, or exceptionally, reporting the C2A2I H6-3D genotype as a susceptibility genotype when associated with other comorbidities, but not as a hemochromatosis genotype. In order to simplify classification, all the other rare or extremely rare forms of hemochromatosis are globally classified as non-HFE-related hemochromatosis. They result from genetic mutations in other proteins of the hepcidin signaling pathway or in hepcidin itself, or very, very rarely gain of function in ferroportin. They are phenotypically more severe, commonly with juvenile onset, contrary to the HFE hemochromatosis, which is typically of adult onset. But they were the focus of another webinar previously given by Domenico Girelli in this Thursdays webinar, so it will not be a focus today. One of the intriguing features of HFE-related hemochromatosis is the extremely high allele frequency of the C2A2I variant in population of Northern European origin, particularly in Ireland, meaning that there is a very high number of people at risk for hemochromatosis in these regions. However, the clinical penetrance of the severe symptomatic form of the disease, namely the one that is expressed by liver cirrhosis and hepatocellular carcinoma, is quite low. And even the biochemical penetrance in some populations can be low. This fact, together with the low frequency of the allele in many regions, makes the symptomatic form of hemochromatosis globally a rare disease, as coded by the OrphaNet platform for rare diseases. So in this platform, hemochromatosis is classified according to the most recent genetic classification, including not only the rare non-HFE-related forms, but also the HFE-related symptomatic form of disease. And the EuroBloodNet incentivizes all clinicians at the reference centers to use these ORPHA codes in their coding systems. So now we move to the main topic of the seminar. Given the nature of disease as an easily preventable disease if detected and treated early, but a potentially fatal one if left untreated, the main challenges are how to detect, diagnose, and treat early enough to prevent the serious complications of iron overload. And the first aspect is to enhance case detection. Unfortunately, there is still subdiagnosis of hemochromatosis, with many patients being detected in late stages already with liver cirrhosis or hepatocellular carcinoma. So first challenge is to enhance case detection. According to the most recent recommendation of EASL, the European Association for the Study of the Liver, an iron panel including transferrin saturation and serum ferritin should be performed in all adult subjects presenting signs or symptoms of hemochromatosis. I believe this is already a common practice in many specialized consultations of hepatology, rheumatology, or internal medicine. Less commonly, it is applied when the general practitioner evaluates very unspecific symptoms, such as fatigue or arthralgias. But if these parameters are found persistently elevated and not explained by other diagnoses, and this is important, not explained by other diagnoses, then requesting HFE genotyping for the C282I variant is recommended. This screening strategy will enhance the detection of symptomatic cases, and the challenge here is to first exclude the iron overload due to causes other than hemochromatosis, such as alcohol abuse or other chronic liver diseases, which also run with alterations in parameters, in particularly when there is hypotransferinemia. That is the case, for instance, in cirrhosis. I would stress that, as demonstrated in this old screening study from US, the IIR study, that the probability that iron overload is due to acquired conditions and not hemochromatosis increases with increasing age of testing and with the finding of abnormal liver function tests. So that's one of the reasons and arguments why the diagnosis of hemochromatosis should be suspected in younger, not in older persons, and preferably asymptomatic. One important detail: when finding biochemical evidence of iron overload, one must exclude also the diagnosis of iron-loading anemias or chronic hemolysis. These conditions can be easily confounded with hemochromatosis, but they are easy to detect with a full blood count and reticulocytes. So in hemochromatosis, anemia is typically absent, so hematological parameters must be always part of the workup for hemochromatosis. Once a homozygous hemochromatosis is confirmed, it is recommended to inform their relatives and propose appropriate genetic counseling to perform predictive testing, especially in siblings, because being an autosomic recessive disorder, 25% of siblings have the chance of having the same condition. I would like to highlight here this study by the REN group, where they showed that the strategy of enhanced case detection, together with introduction after 96 of the genetic predictive testing in first-degree relatives, effectively contributed to a reduction in the clinical expression of hemochromatosis, particularly the severe liver disease, as you may see in the left graph. Curiously, as you can see in the right graph, the significant decrease in severe liver disease, that is the orange line, was not related with any decrease in the age of diagnosis, that is the upper dashed line. That maintains at around 40 years, suggesting that we are not diagnosing earlier, but we are detecting less penetrant forms at all ages. If you notice the end of the orange line, it means that still 20% of cases are diagnosed with severe liver disease. So to decrease further these numbers is a real challenge. So, although there is no doubt about the benefits of family screening, the question remains about general population screening. Should we do it? And how should we do it? Recently, the federations of the associations of patients with hemochromatosis, the Hemochromatosis International and IFAB, challenged their joint scientific committee to launch a survey to all experts in the field in order to find a consensus on hemochromatosis screening that could be reported as a position paper by the patients' associations. The questions addressed were: should population screening for hemochromatosis be recommended? Which tests should be used? And at what age should population screening and follow-up occur? And we consider consensus defined as more than 75% agreement on each question. The results show that experts achieved consensus for screening for HFE-related hemochromatosis in high prevalence population, that is more than 0.4% allele frequency, and before the age of 30 years. This was consensual. But no consensus was found among experts about the ideal methods for screening, because biochemical screening with transferrin saturation has the problem of being unspecific, eventually leading to a heavy strategy of screening for other liver diseases. But genetic screening has the problem of the low penetrance, eventually creating unnecessary anxiety and overtesting in people who would never develop hemochromatosis. One of the arguments that some experts are advancing to defend the idea of genetic screening is this recent study using the UK Biobank data. This is a biobank with about 450,000 European participants, followed up for 13 years, and almost 3,000 were homozygous for C2A2I. The vast majority not having been diagnosed before. So this is mainly a population of homozygous not diagnosed before. We don't know if they are treated or not, but apparently they are not because they were not diagnosed before. Male homozygous subjects showed an increase in all-cause mortality and morbidity relative to non-homozygous subjects, and most importantly, a significant increased risk of liver disease, in particular cirrhosis and hepatocellular carcinoma. Notably, subjects with supposed susceptibility genotypes of compound heterozygosity, C2A2I, H6-3D, or H6-3D homozygosity were not different from subjects without any of the variants, further reinforcing the idea of these subjects not being at risk for hemochromatosis. When analyzing the cumulative incidence of liver disease in C2A2I homozygous males, the results confirm a low clinical penetrance, with only 20% of subjects having been detected with liver disease until the age of 8 years. So the question here is how to predict this outcome at a younger age without adding the burden of a putative diagnosis in 80% of persons that will never develop liver disease. It is possible that identifying young asymptomatic subjects with evidence of iron overload is predicting the potential symptomatic cases, but of course, this needs proper demonstration studies. Another way to predict the risk would be to identify genetic modifiers of the clinical penetrance. And this question was also approached with data from the UK Biobank, and the results identified several polygenic risk scores for iron measures and for hemochromatosis-related conditions, meaning that these risk factors are not specific for homozygous patients, but the same as found in the normal population. In our group, we are particularly interested in this question, and we are focusing on NRF2, a transcription factor that senses the iron-induced oxidative stress, regulates iron levels, and protects against iron toxicity. Our hypothesis is that what modifies the clinical expression is not only the amount of iron that accumulate, but the way they respond, the defensive response to the iron toxicity, and NRF2 is a good candidate for that. In a preliminary study, we have found that patients carrying a particular genotype, that here is indicated as TT, the orange dots, it is a genotype that corresponds to a phenotype of low expression of NRF2, and they had higher total body iron stores, as you see in the left graph, and liver function enzymes, as you see in the right graph, but they also had a significantly higher frequency of liver cirrhosis, 25% against 5% for those who did not have that genotype. This is a promising finding that we are now pursuing with an extended cohort of patients. Finally, I will address some challenges in treatment options. The standard treatment of hemochromatosis is therapeutic phlebotomies. The first objective is to remove the iron accumulated in the liver and mobilize it for erythropoiesis. This is done in the intensive phase of treatment, usually with weekly phlebotomies, until reaching the target ferritin value of 50 nanograms per ml. The second phase consists of maintenance phlebotomies, usually every 3 to 4 months, in order to prevent the iron reaccumulation. One point, hemochromatosis subjects without complications of iron overload can perform their maintenance treatment as regular blood donors if they volunteer for that. In this recent study by Laura Infanti and co-workers, they provide a very nice short review on hemochromatosis and blood donation. Although there are well-established regulations on both European guidelines and FDA to permit the collection of blood from subjects with preclinical hemochromatosis for blood transfusion, the real-life practices of blood donation for hemochromatosis are still very heterogeneous among countries and centers within the same country. So some centers still do not accept hemochromatosis subjects as volunteer blood donors. This is a current concern of the associations of patients, and the challenge is in fact to harmonize practices so that all may be treated with the same criteria. Either performed at a hospital service or in a blood bank, treatment should be monitored. In these graphs, you can see individual values of transferrin saturation, the upper graph, and serum ferritin, lower graph, during intensive treatment, that is the time until reaching the day 0, and during the first year of maintenance treatment. Ferritin is the most simple and reliable marker to monitor iron stores, and it is recommended to be maintained between 50 and 100 nanograms per ml. Please note that these values that we use in hemochromatosis in other conditions, such as renal disease, or so, are even considered iron deficient values. But in hemochromatosis, these are the values that should be maintained to guarantee that there is no reaccumulation in tissues. And there is no danger of iron deficiency in hemochromatosis. Transferrin saturation, on the contrary, is not a good marker for monitoring maintenance treatment. It tends to increase again to abnormally high values with a high variability among patients. It reflects the dynamic of iron absorption and circulation, but it is not an indicator of iron reaccumulation in tissues. This is important to explain to patients who many times are worried when they check their values and they ask if their body is accumulating again, and the answer is no, as long as ferritin is maintained on target levels. Another common question posed regarding maintenance treatment is, should hemochromatosis patients perform maintenance treatment not by the level of ferritin, but on a regular basis to keep the low ferritin values? This is, of course, a question that before it was impossible to ask because we could not make a trial putting patients on treatment and patients not treated. But we had a unique opportunity to address this same question due to the contingencies imposed by the COVID-19 pandemic that obliged our day hospital to close from March to May 2020. So the hemochromatosis patients regularly followed at this center had to interrupt their maintenance treatments, which were usually programmed every 3 months in males and 4 to 6 months in females. After the 2 months of lockdown, patients were rescheduled to resume their treatments. At that time, some patients still fell within their regular time schedules, but many of them delayed their treatments by periods that in some cases exceeded 1 year. This happened not only because of the lockdown, but also by their own decision, many times for the fear of the hospital environment for some time. In this setting, we calculated for each patient a variable that we call time lapse as the number of days between the pre-lockdown and the first post-lockdown visit, and tested the variation in ferritin in relation to time lapse. And what we observed was that if not treated, ferritin increases at a predicted rate of 100 nanograms per ml per year. And this is an argument to recommend regular maintenance treatment. You can imagine 100 nanograms 1 year could be 1,000 in 10 years. There is also the question, if there are no novel treatments available to compensate deficiency of hepcidin. Several hepcidin agonists have already been developed, validated in preclinical studies, and some already passed phase 1 trials. Some of these are so-called hepcidin mimetics, targeting ferroportin. Others are hepcidin stimulators through targeting TMPRSS6, that is a protease regulator of hepcidin synthesis, and there is now ferroportin inhibitor in phase 1. What I should stress here is that all of these options effectively decrease transferrin saturation by inhibiting iron absorption and retaining iron in a non-toxic form in the reticuloendothelial system, but they do not mobilize the iron from the liver and eliminate it from the body, such as phlebotomies do. So these are interesting future options for maintenance therapy, but do not substitute intensive iron depletion treatment. So my take-home messages. The major challenges in the management of HFE-related hemochromatosis I consider to harmonize and implement among clinicians a correct diagnosis, classification, and treatment of hemochromatosis, and to implement strategies of population screening according to national regulations and demonstrate results, because only demonstrating these results, it could be applied as a common strategy. And promote research. Which are the topics for research? I find that the main topics for research are the pathogenesis of arthropathy. This is practically the major clinical problem in patients in the era post pre-symptomatic diagnosis, because sometimes arthropathy can develop independently of iron depletion therapies. So understanding this has implications for treatment. Modifiers of clinical penetrance, because it has implications for screening strategies, and fundamental research also. We cannot forget fundamental research, because we still don't know exactly all the functions of HFE as an iron sensing molecule. We understand well the iron sensing in the liver, but we don't know other non-canonical functions of HFE. For instance, if it could also be an iron sensor for hematopoiesis, and this would have implications for treatment also. But the interesting thing should be to ask patients, what do they consider the research priority? And this is the study that Beatrice mentioned before. That was a study promoted by the World Federations of Patients with Hemochromatosis, where they asked which were the priorities they found for research. And the results, when analyzing patients' preference in hemochromatosis research, they selected conduct research into arthritis and joint problems as the top priority in hemochromatosis field, closely followed by promote knowledge about hemochromatosis among medical doctors. And the third most voted choice was investigate new or alternative treatments for hemochromatosis. So I think we are in line with the hopes of patients to do more research and promote more knowledge on hemochromatosis. So I thank you very much for your attention, and I am ready to answer to your questions.
Thank you very much, Graça. So may we can stop sharing the screen maybe, so we can look at the
yeah. Okay.
Yeah. And maybe so it's open for discussion in the chat. So I think that you and myself, we can
in the chat.
Look in the chat. So I have it, no problem. So don't be shy. It was really very interesting. Thank you very much, Graça. Especially for the change, for example, in the diagnosis with H63D. Yeah.
Yes, this has been a current problem through the years. And it's curious because it's not only among experts and the patients in the meetings of the patients, they are always coming back to that because they are confused, of course.
Yeah, I understand. So I have some relatives.
And it's very difficult when one patient is diagnosed as hemochromatosis genotype than to tell him, well, after all, you don't have hemochromatosis. That's difficult. Yes.
Yeah.
We had that experience. I remember it was in 2003 that we had to call all the patients and say, okay, we can be wrong. This first was thought as a hemochromatosis diagnosis, but now it is not, because it's really important not to put that label, because putting that label would prevent them to follow other instructions, namely in lifestyle habits and other things that they should do and not rely on a genetic characteristic. Yeah.
Okay, so nobody has question? So it was so clear, Graça, that
either was clear or
yeah.
completely.
No. It was really very clear to me, at least. I learned a lot. And then also at the end, when we see what are the priorities from the patients. So and you highlighted before with arthritis.
And I would like to stress another thing, because it was this year the EuroBloodNet promoted the change in the nomenclature in orphanage. Because HFE hemochromatosis, there was much discussion if it should be treated as a rare disease or not. But as a matter of fact, it is important that he has this label to have the focus to be screened, to be diagnosed earlier, and so now definitely the orphanage classification is now clear. And it includes also in the rare diseases. Yes, of course, sometimes patients' associations don't like very much that it is considered a rare disease, because they want to promote that is very, very common, but that is one of the problems that has led to much confusion, because advertising as a very common disease, it was clearly confounded with other forms of iron overload that are really common. So the iron overload secondary to this metabolic syndrome or chronic liver disease, it's really common. So there was this confusion. So labeling is important.
Okay, thank you very much. I don't see any
Flavia Santos.
No, nothing. No reaction, nothing. So I think it was really clear. So I thank you very much, Graça. And for all the participants, you know that the webinar has been recorded and will be available on our website, YouTube, and so on. Okay, so have a nice evening.
Okay, thank you. Thank you for this
Bye-bye.
opportunity. Okay, thank you.
Thank you, bye.
Bye-bye.